Assalamu alaikum, dear physicians. Welcome you all in today's lecture series organized by ECG Study Group. Today is our 40th lecture, and today's topic is ECG for fun. And as usual, the fun part of ECG is always going to be presented by our respected and most liked teacher, Dr. Rafique Ahmed sir. Before starting our lecture, I request Professor Abdul Wahid Chaudhary sir to say some words about Rafique Ahmed sir, and then we proceed. Wahid sir, Assalamu alaikum.
Assalamu alaikum everybody and good evening. Today we are going to have some beautiful ECG from Professor Rafique Ahmed sir. Rafique sir, I think is well known to everybody who is joining here today. Still then I have to say a few words. He's somebody who stays in USA far away, but always continue having the dream of any Bangladeshi people in his mind to enlighten this country, to improve the country, to serve the country. That's the dream he always bears in his mind, and that he executes by his action. He's the founder of electrophysiology of this country. And for that, he has to sacrifice a lot, spend a lot of work hour, have to spend a lot of time in this country, come to this country again and again, and have to bring the experts, the logistics and everything to start this electrophysiology service in this country. When we started this ECG study group and he joined it, it enlivened us like anything. And the most important thing about him is that he is capable of making things very pleasant, very fun-filled, very, I should say, enlightening. So today again we are going to have a beautiful lecture from Dr. Rafique Ahmed, consultant cardiac electrophysiologist in Manchester Heart and Vascular Institute in Maryland, USA. But before that, his most important, I should say, porichoy is that he is a Bangladeshi origin electrophysiologist. That's the most important thing. Thank you, sir, for joining us, and we are waiting for your beautiful lecture.
Sir, you have to unmute yourself, sir.
Okay.
Yes.
Good afternoon, good evening, and Assalamu alaikum to everybody. I want to ask Arun a quick question just to confirm. I heard that Siddhartha passed away. Is that true, Arun?
Who Siddhartha?
Cardiologist in Nepal, Siddhartha Majumdar.
Siddhartha Majumdar, cardiologist from Nepal. I'm not aware of.
Somebody, okay, anyway, somebody mentioned that. Anyway, so today's lecture was supposed to be by Athar Ali, but Athar's mother is very sick in the hospital, so please pray for her. I mean, we are all in that region passing through a difficult time, and I hope we will recover from this. So I'm going to do, because Athar's lecture was supposed to be anatomy and physiology, I'm going to touch a little bit on the electrophysiology mechanism of arrhythmia. So can we get a volunteer to tell me this about this ECG? Because I didn't put questions. I thought that. Tushar, can we have somebody?
Sir, I like to request Arun Maski sir to have someone from Nepal to participate. Maski sir.
Okay. So can I ask, can you unmute Bisal Shrestha? Bisal Shrestha? Unmute. Rivu?
Rivu, please unmute Vishal Shrestha.
Okay, Bisal.
Yes.
Vishal, you want to say something? Is he on mute?
Anybody else?
Can you unmute Vishal?
Sir, is he Dr. Vishal Shrestha?
Yeah. Yeah.
Okay. I'm bringing him. Yes, sir. He has been allowed to talk. He has to
Okay,
unmute.
Michelle, can you tell me about this ECG, please?
Sir, should I continue?
No, yeah,
Yes,
Vishal
sir.
is there.
Okay.
Am I audible,
sir?
Vishal? Yeah.
Yes.
Yes. Mr. Vishal, you are audible.
Yes, sir. This is a two-way lead ECG showing group beating. First initial 6 beats are around at the rate of around 60 beats per minute, and later on the rate is quite high, around at the rate of 150 beats per minute, 120, 150 beats per minute. The
Okay.
P wave is present in all the leads preceding QRS. We can see white P wave in lead 2, especially in the initial part, whereas the P wave is different in different later parts. So there is multiple morphology of P waves.
Okay.
And the axis is left right axis around minus 45 degree, and then the QRS PR interval is okay. QRS interval is okay. QRS axis is right axis, and then we can see Q waves in V1 and V2. However, there is no other Q waves and no other ST changes. QT seems to be prolonged on the later part of the ECG. Probably not.
Thank you. So I think you have summarized it. My question, there is of course evidence of left hand, but you did a wonderful job. So if people who are listening, please look at this, that what he did is he did not just focus on the abnormal finding, he described the ECG and talked about all the pertinent features, including the presence of Q wave in the anterior chest lead. My question to you now is, so the P wave here is V1 biphasic, so this is sinus. Even though it looks multiple morphology, but if you look at lead V1, it's upright morphology. So what is the reason for this tachycardia? What will you diagnose this as?
As the P wave as morphology has changed from before tachycardia, then after tachycardia. So I'll consider it as supraventricular type, sir. Probably inappropriate sinus tachycardia or atrial tachycardia.
Okay, between inappropriate sinus tachycardia and atrial tachycardia, which one would you take?
So I'll take for atrial tachycardia.
Good. So the reason you are taking atrial tachycardia, because if it were sinus tachycardia, for whatever, it cannot suddenly jump to this rate, number one. Of course, by broad definition, this is supraventricular tachycardia. Now, if you look at the relation between P and QRS, this is a long RP tachycardia. A long RP tachycardia, there are two diagnoses. One is atrial tachycardia, and one will be possibly atypical AV node reentry. However, if you look at it here, and look at this T wave, and this one, there is distortion. So probably there is a P wave here. So it starts with a P wave. So this is most likely an atrial tachycardia. Now, my question to you is, why did it happen? What is the mechanism? You don't have to be correct, just give me a guess.
Probably the patient has a left atrial enlargement, sir. Some mitral valve disease.
Okay, sure. I mean, we don't know. I don't have a history of this patient. I did not put the age or anything, so I have to be fair to you. So the question is, why did it happen? Is it suddenly some focus in the atrium became faster? Is it a re-entry? All those are the mechanisms that we're going to. Thank you very much. So
thank you, sir.
What happens is, automaticity. Automaticity is can cause tachycardia. And the simplest example of automaticity is sinus tachycardia. If I am sitting down, my heart rate will be 60. If I start running, my heart rate will go up. And that will be an enhanced automaticity of a normal sinus node. Or I can have a totally abnormal focus somewhere in the heart, which can start beating. This is the action potential of the sinus node. You see, this is a sinusoidal wave. This is minimum diastolic potential. This is threshold potential. You don't have to remember this, but just threshold potential means that if the cell reaches that level, it will then generate an action potential. We can have increased atomicity because the threshold has gone down. If it is here, then it will start earlier and we'll have tachycardia. Or the diastolic potential goes up and we will reach threshold much quicker. It will be faster. Or the slope changes of the phase 4, and that's automaticity. In inappropriate sinus tachycardia, this is the most likely mechanism, and drug like ivabradine actually works here. So if there is a popular drug ivabradine, it is a funny current that causes this, and so it's important to understand these things and really use drugs appropriately. And for the newer generation of doctors, please remember, when we became doctors, we did not know the mechanism cellular level. There is a lot of cellular research going on, and they are finding out the target location of action of these drugs. So this is enhanced automaticity. That it can be physiological, it can be pathological. Physiologically, sinus tachycardia. This is an example of a patient, 51-year-old, heart rate 123. You can see there is a P wave before each QRS complex. The P wave is upright in lead 2, 3 AVF, lead 1, and probably it's difficult to see here, but probably biophysics. So this is a patient with sinus tachycardia. This is an enhanced automaticity, but this is a physiological enhanced automaticity. I don't know the circumstance in which this patient was, but this is most likely a sinus tachycardia. I always tell people one thing about if the patient is on telemetry monitor, if your patient's heart rate is 123 for 15, 20, 30 minutes, that cannot be sinus tachycardia. Please remember, sinus tachycardia, even in the sickest patient, will have some inherent variation. So what are the enhanced automaticity tachycardias? That we can have supraventricular premature beat, we can have ventricular premature beat, we can have atrial tachycardia, and there are certain ventricular tachycardias due to enhanced automaticity. That among them are RVOT, VT, LVOT, VT, and this is way to do it. Actually, in electrophysiology study, there is a way to differentiate. A lot of times it's very difficult to differentiate these tachycardias, whether it is automatic focus or is it a reentry. But if you study them, one of the simple way would be if you give a drug like isoprenaline that induces tachycardia, that is most probably enhanced automaticity. On the other hand, if you use electrical extra stimulus technique, most probably it's a reentry tachycardia. So anybody for this one, please? Tushar, can you get somebody to do this?
You want Dr. Krishna Chandra Adhikari?
Sure.
Can you unmute Krishna Chandra Adhikari?
Yes, okay, sir. Just give me a moment.
Krishna?
Yes, sir.
Okay.
Hi, this is Dr. Ahmed. So what do you think of this arrhythmia? Start with the top strip.
To speak, Dr. Krishna.
It's a rhythm strip. With regular whitish, irregular white tachycardia. Probably, sir, it's torsadi pointis.
Sure. And what is the, so Why did you say it's torsade?
So there is a differing amplitude of the ventricular complexes.
Exactly. So what happens with torsade? Some of them will look down, like here. If you look, I'm sorry, let me get the pointer here, like this one, looking down, and then changes looking up. And there is another thing that supports it. What do you think of the QT interval?
QT interval in the previous, in the early part is prolonged, sir.
Prolonged. So prolonged QT. So what do you think is the mechanism of this arrhythmia? Why did it happen?
Mechanism.
Yes. All right. You don't have to, but so this is after depolarization. And stay with us, please. When
Yes, sir.
we have action potential in the ventricle, you see these are triggered by something. Ventricle normally will not generate. Ventricle will follow the atrium, or if there is a PVC or something, automatic focus. So, but this action potential can sometimes generate after depolarization. And this is linked up to this one. And there are some of them are called early after depolarization, and some are delayed. And so if, let's say, there is a delayed after depolarization, if the amplitude is big enough that it can generate an impulse. Like this one, early after depolarization, and it is big enough, it can produce a complex. And look at this. If you think about it, here is the wave where is the ending of that early action potential, and then there is the impulse that started from here. And that's early after depolarization. That's the mechanism of long QT, drug-induced torsade, or long QT due to bradycardia for this patient. I'm not going to talk, thank you very much. I'm not going to talk about the treatment. So please remember this, that delayed after depolarization and early after depolarization. And depending, why is it important? It is important because how to treat this. What's happening? Let's look at picture B. The action potential is prolonged, and that is causing this action. So if these patients come to me and I think this is VF or VT and I give them amiodarone, it will make it worse. So if it is after depolarization related, it will make it worse. In delayed after depolarization, if there is an offending drug, that will have to be stopped. And this actually is a calcium current dependent. That's why a lot of times calcium channel blocker will prevent in digital toxicity. This is potassium current dependent. So after depolarization, there can be different types. Phase 2, this is calcium, inward calcium current. Phase 3 is potassium current, and delayed after depolarization is the late one. And what are the types? Early after torsade, long QT arrhythmia, all of them are early after. Delayed, perfect example is digital toxicity. And so they produce atrial tachycardia by delayed after depolarization. And then oxalative idioventricular rhythm, reperfusion arrhythmia, all those are related, and some RVO to VT are actually delayed. And this is a unique one. Catecholaminergic polymorphic ventricular tachycardia. We used to think this is a rare entity, but it is not. It is, again, this one actually is very much dependent on calcium current, and there is calcium overload inside the cell.
Sir,
Now,
just as a question, I have a question, if you don't mind.
Yes.
Sir, why the catecholaminergic polymorphicity is more common in children? Is there any mechanism?
I don't know. I'm not sure. Is it? We see very rare young people, because these are idiopathic ventricular arrhythmia. So I don't know why it is more common in children, or is it possible that this arrhythmia is a genetic condition, and basically the one that we see as an adult, and they are diagnosed early on. That probably is the most likely explanation. We don't really know the gene involved in this. Thank you. So reentry, this is the commonest mechanism of arrhythmia. Concept of reentry is very old. It was started in the early 1900s. So what do we do? Let's say we take a tissue, circular tissue, and it was tested on jellyfish, and I put an electrical signal here. Electrical current will go in both directions, and it will collide in the middle and then disappear. Nothing will happen. However, let's say I block it here by some pressure or some mechanism and put an electric current here. Electricity will not be able to go this way. It will come this way. And then by the time it reaches this point, if there is a tissue has recovered, it can go round and round and producing a reentrant arrhythmia. And this is the commonest mechanism of arrhythmia in our practice. And it can be big reentry. That means you can have a huge big circuit involving the whole atrium, or it can be micro reentry in a small part of the atrium or the ventricle. So let's look at this, how this happens. This is the tachycardia. Even though this is reported as sinus tachycardia, we have discussed this before. This is a ventricular tachycardia, relatively narrow keyword is ventricular tachycardia, and rate of 135 beats per minute. Same patient, a little bit slower rate. So what can happen? The reentry can happen because there is an anatomic barrier, or we can develop a functional barrier. Functional barrier concept is a little difficult to understand, but it is possible. Anatomic barrier will be, I'll give a perfect example, will be, let's say, we'll come back to this. And this anatomic barrier can be physiological or pathological. Let's say we have in the right atrium, we have inferior vena cava, and we have tricuspid valve. And both of them are electrically non-conducting, and you can have electric current going between these two up along the wall of the septum and then come back. I'm doing it in a reverse way. It can go round or the other way around. And that's a natural anatomic barrier. That's the mechanism of atrial flutter. On the other hand, we can have a scar tissue due to myocardial infarct. Let's say these are the infarcted tissue and these are healthy tissue. Now, what happens if this healthy tissue conduction is slow? You can have electricity going down the normal myocardium, goes slowly through this pathway and come out and then produce this Kivarius complex and then go back and come out again, produce the next one. And that's the mechanism of ventricular tachycardia. So how does antiarrhythmic drugs work? What we do, we give antiarrhythmic drugs, we block this pathway. How does ablation work? I can take a catheter. If I can find this focus, easier said than done, you can actually ablate this location and it will stop the tachycardia. So this is a scar-related ventricular tachycardia. There is another that's common arrhythmia that is present is when people undergo atrial septal defect by the old technique, they will cut the atrium and they will produce a scar tissue. You can develop an atrial tachycardia around that scar. And so when you go back, you can find the scar and ablate it. So the other reentry can happen in the bundle branch. So let's say electricity is going down through the right bundle and then comes back through the left bundle, producing a left bundle morphology tachycardia, which is more common, or go around that, or you can produce reentry inside these fascicles. So the bundle branch reentry is more common, left bundle type. It is more common in dilated cardiomyopathy patients with some conduction tissue defect. And interesting, good thing about it is that if we understand the mechanism, treatment is very good, easy. If we can ablate the right bundle, I can stop the tachycardia. And that's why the understanding of mechanism of this tachycardia is very important. So then this is a very big slide. We can have reentry in the sinus node. We can produce sinus node reentrant tachycardia. And what happens? The POA morphology will be exactly same as sinus beat. So the first ECG that I showed, if the POA morphology was similar to the sinus, I could have said most probably this is sinus node reentry. And what we can do, we can go and ablate part of the sinus node or try medication. Sinus node reentry is more common in elderly people. It has no clinical significance except that it's a nuisance. You can have reentry within the AV node. Even though AV node we always draw the circular structure. It's a little bit bigger structure and you can produce reentry around the AV node. You can produce atrioventricular reentry using an accessory pathway. And look at this. And if I have a reentry in the AV node, the electricity will go back to the atrium and into the ventricle at the same time. That's why the P wave will be inside the QRS complex most of the time. On the other hand, if you look at this arrhythmia, that electricity goes down to the AV node, produces the QRS complex, then goes into the atrium. So the P wave will be after the QRS complex. There are exceptions, but this is how it happens. Atrial fibrillation is different. It's a totally different ballgame. The theory is that there are a lot of micro reentry circuits in all over the atrium. And that's why they're difficult to treat, difficult to ablate. If you have a single reentrant circuit and you can find it, you can ablate it much more easy than atrial fibrillation. So this is tachycardia. You can see the narrow QRS tachycardia at a rate of about 100, slightly over 150. And I think there is a P wave immediately behind the QRS complex and within 80 milliseconds. How do I know this is P wave? It's something that we don't normally see. And when the patient converts after adenosine, sorry, I didn't put the normal slide. When the patient converts, you cannot see it. So how does it happen? The AV node can have slow pathway. As I told you, that this is pictured as a round structure. AV node is not a round structure. There are a lot of extension here. That is the area that can go slowly. So if there is a atrial beat, a premature beat, this is a sinus beat. It comes down, goes to the fast pathway, blocks into the slow pathway because fast pathway goes faster. Now, if there is a premature beat, what can happen? The premature beat can block in the fast pathway, go down through the slow pathway. Why does it do that? Because fast pathway has faster, longer refractory period. So it goes down. So here nothing happened. However, if this electricity could go backward, if the pathway is open, it could go and then keep going round and round, producing AV node reentrant tachycardia. And treatment will be that I can take medicine to slow down one of the, most likely the slow pathway, or I can put a catheter around this location and ablate here. So we're going to modify the slow pathway and tachycardia can stop. So this is a reentry. This is the very common reentry mechanism. Now what happened with this one? This is another narrow QRS tachycardia. You can see that there is possible PA wave. Of course, Hafiz will question, oh, the UEP doctors always make things up. We do make stories up to make it palatable. So here is something that is consistently present. And so there is a RP and PR tachycardia. And the same patient, when it converts to sinus rhythm, you can see there is delta wave, there is pre-excitation. So that is an atrioventricular reentry. How does it happen? It happens, electricity goes down through the normal pathway, producing a narrow QRS, and then come back, produce the retrograde P wave sooner. If it goes the other way around, antidromic tachycardia, you will have wide QRS supraventricular tachycardia. And then it becomes very confused. It can look almost like ventricular tachycardia. Atrial flutter. This is another common, it's kind of interesting that it's very common in the United States. For some reason, in Bangladesh, it is not as common. In Bangladesh, fibrillation is more common than flutter. I don't know about Nepal or India, but this is a sawtooth appearance. What happens? The mechanism is, this is the inferior vena cava, and over here will be the IVC tricuspid annulus. The electricity goes down along the lateral wall of the right atrium, and then comes back up through the septum, producing the typical atrial flutter. If it goes this way, it will produce atypical atrial flutter. So this is a macro reentry circuit. Again, this is one arrhythmia that is very easily curable and with almost 100% success of ablation if you ablate the IVC tricuspid annulus to the, IVC to the tricuspid annulus location, and it can be done. Now, there is another type, as I told you, that people who undergo atrial septal defect repair, they cut that. The old technique would that they would cut the atrium and suture it. Problem is, they now have left a tissue here, which is healthy, and this is a scar around which you can produce reentry circuit. Now, what the surgeons nowadays do, they will bring this line to the IVC. So the newer technique, they will always draw a line from here. So you don't have that opening to produce the reentry circuit. And this is, we can do electronic mapping, we can define the circuit, we can find where the slow conduction narrow zone is. One thing about ablation that I'll tell you that you have to find a critical area where you can do. I'll go back to this picture. This is for the younger doctors. Look at this. If I do ablation here, what will happen? The circuit will only move around it. However, if I do a line from this to the IVC, then there is no way. It is a narrow area, number one, and this is where the critical isthmus is. So when we do ablation, the time that is spent is finding that critical narrow area where this electricity is going through and ablate it. So I'm going to stop this part of the lecture. If there's any question, I will take it. And I'm going to change the slide. Any questions?
Hi, me, Dr. Salam.
Yes, please welcome.
Yes, sir. Sir, nice to see you, sir. Again, I was a bit late. I have a question that is in case of device closure of HD, I had a patient who presented with syncope and followed by convulsion. And we found incidentally after echo, there is a big hole that is atrial septal defect. And patient was admitted in ICBD and subsequently we went for neurological evaluation. Is there any focus of epilepsy? But unfortunately it was not there. And then we went for device closure and successfully the patient improved, and further subsequently on follow-up we did not found any syncope, any atrial flutter or fibrillation. So my question is, surgeon is cutting and suturing, but we are putting some foreign bodies, but how this arrhythmia has reverted to normal? This is my question.
Well, thank you for the nice question. First of all, the question is, the surgeons open the chest. This patient's syncope, you have never diagnosed the etiology. So we don't know the etiology of this. Because if we look at it, by definition, an atrial septal defect cannot cause syncope. It can cause stroke or other symptoms. So that's one. So of course, the ASD closer now, as you pointed out, that a lot of them can be closed by the closed technique, transvenous technique, but still a good number will still end up needing open surgery. This group, actually, we have seen arrhythmia with this group also. The problem with this group is that once they have arrhythmia around the septal occluder, you can't go and try to ablate it because you have foreign body there, and it'll be and metals, and you may end up damaging those. So if they develop arrhythmia, we are kind of in a bad situation.
But Rafique bhai, his question was how it prevents arrhythmia in future. I think we can reasonably say that because of the high flow, there is with the atrial septal defect, there is atrial remodeling, atrial size goes up, and it becomes like a substrate. The more a shunt, the atrial dilatation, more the arrhythmias. So once we close that, it reverses that remodeling phenomena, enlargement, and then probably beneficial in the long run.
Yes, no question about it. But the question is, in this particular patient, we have no proof what are the etiology of syncope. That is the problem. But no question about it, that if there is atrial stretching, there will be arrhythmia in future. And that can actually cause problems. So by doing the ASD closures, we are probably helping the heart and preventing unnecessary stretching. Thank you. Anybody else, any question?
Hello.
Yes.
Hello.
Yes,
Sir?
I can hear you, Sadiq.
Sir, I want to know one thing. 3 days back, one patient in our hospital presented with acute clockwise, counterclockwise flutter.
Yes.
3 times attempted with synchronized defibrillation with about 200 joule, but 3 times, despite of 3 times defibrillation, the shock failed. Ultimately, Dr. Mohsin terminated the flutter by ablation. My question is why the 3 times synchronized shock failed to terminate the flutter?
Yeah. So the question is, why did not flutter terminate? Did you do the cardioversion or somebody else did it?
The cardioversion, sir.
And who did it? You did it or somebody else?
We are present there.
Okay. Did it convert at all? You see, this is what it is. Cardioversion not converting, I do a large number, is extremely rare, especially atrial flutter. Number one is the placement of the pads. Where are you putting the paddles? In Bangladesh, I'm sure you use the paddles. We use pads. We put it anterior posterior. I am yet to see a flutter that did not convert. But it is possible that sometimes they will convert and then go back within 1 beat or 2 beat, they can go back to the flutter again. So a new onset flutter, we always cardiovert. It's extremely rare for flutter not to work. And the other thing is, was it a monophasic shock or biphasic shock? We have devices with external 360 biphasic, but most flutters stop with low energy shock if the pads are rightly placed. So that will be why I will look into where the pads are. We always do our own cardioversion. And the thing about doing this thing is that it's a small procedure, but the cardioversions are always done by physicians in over here. Thank you. Anybody else? Hafiz, you want to take over, or do you want me to do something else?
I don't know how much time we have.
You have time. So I have to go, and if you don't mind, thank you all. And Hafiz, you have slides ready?
Yeah.
Okay. Hafiz will I take over, and then I'll see you next week. I'll stay until another few minutes.
Sir, can I ask you a question, sir?
Sure.
Sir, following RFA ablation,
Can you see my slide?
Let me stop. I have stopped, right? Yes.
Can you see my slide now?
No, not yet.
No, sir.
Okay.
Go ahead, Tushar.
Sir, following radiofrequency ablation, the scar we make inside, what is the chance of re-entry around that scar?
Oh.
Any ablation?
Sure. So the question is, what is the chance of, if you do a venous reentry tachycardia ablation, it should be a single spot ablation, and that should not produce a scar, big scar. If you do in children, young kids, then actually a 1 millimeter lesion can go up to 1 centimeter when they reach adulthood. So that can produce scar. And one of the typical example, what you were mentioning, happens with AFib ablation, because that's more extensive left atrial ablation. And you are drawing many lines, and there are actually tachycardia going around those curves, just like the ASD incision. And sometimes you have to go back and re-ablate those areas, find out where it is happening, because you'll see that a lot of AFib patients will go into atrial tachycardia after ablation. So you ablate those. But for WPW syndrome, for avenue reentry, I don't think that's an issue, or focal atrial tachycardia. That should not be an issue.
Sir, in many cases of WPW, we have to ablate quite long area, as is the course is as its course is sometimes oblique. So does it produce scar that can in the future produce a reentry?
Oblique WPW syndrome pathway is not very common. So
That
if
is not
you are
confirmed, sir,
mapping,
but
if you are spending enough time, you can find the location. And our practice is to minimize as few ablation as possible. Most of WPW syndrome, AV node reentry and tachycardia, we will give 1 to 2 ablations at best. There are very few. So that's why you have to be patient during EP study. You sit and find the location where the ablation is going to work, and then ablate. And that's where it comes to the mapping part. And there is, of course, always a tendency, oh, I found the pathway, let's ablate as quickly as possible. That will lead to giving too many ablations.
thank you, sir. Thank you.
Rafique, can you see my screen now?
We can see your screen, but not the slides.
Oh. Can you see my now?
No, we can see the list, ECG Basic Beyond, all those things, but not the main picture.
Oh.
You want to double click on that?
No. Okay. How about now?
Black screen. Oh, yes, it's coming up now.
Okay, good. So this is a 40-year-old. Some of the EKGs, I call it the, when you go to a restaurant and they say, catch of the day, the fish, Rafique bhai, in your Maryland harbor side, the catch of this day. So this is the catch of the day. 40-year-old female with complaint of chest pain and called EMS. She takes losartan for hypertension. And the EMS found her in chest pain, and in front of them, patient went into a rhythm like this and lost consciousness.
Like this.
Was that? Sorry?
Like torsion.
So, patient lost consciousness and then went into this. Rafique bhai, will you call it torsade or will you call it VF?
I'll call it VF because it's you can really make the head and tail of it. I'll call this ventricular fibrillation.
So they gave one shock, and then patient came around and was return of circulation, was talking, some kind of chest pain, and then EKG. Sorry about the quality of the tracing. And then EKG, some ST elevation in the precordial leads. That is immediately after a repeat B. You can see the B EKGs, and then patient came to the ER, and then EKG in the ER. So no family history of sudden cardiac death. Patient had never any cardiac history before. Hypertension and this story. So Jamil bhai, and of course the emergency room doctor wanted STEMI activation.
And Hafiz bhai,
yeah.
The first ECG in this case, the A, and the B1 and B2 looks like
like some ST elevation, right?
ST
But
elevation
then,
with concavity up.
Yeah.
In B2, somewhat saddle type.
Yeah.
But look at the QT.
Yeah. QT is QT seems to be less than half. of the
Yeah, QT is okay.
is normal.
And in case I don't see the ST elevation, the ER doctor put arrow mark in lead 2-3 AVF. See that? They put that there is ST segment depression in case I miss it.
It's due to undulation of the baseline.
And then you can look at the B, EKG B, and then EKG C. The bottom line is that what do we do next? And that was the question. So I was called in, and what to
Hafiz,
do next.
Can I make a comment?
Yeah.
If you go back, please. So this patient never had chest pain, right?
No, patient complained the emergency medical service for chest pain. Emergency medical service, when they arrived, they were talking, and
okay. That made it difficult. So you can't blame the ER doctor to call you. I mean, it's a concave ST elevation. One of the issues, one, acute ischemic event versus is it Brugada? Brugada can have dynamic EKG change, but how do you explain the lateral T wave changes subsequently? It's very difficult, just by Brugada.
Right.
So the ECG-C in lead V2, V3, V4, there is T wave change now.
Yes. And then in the leads EKG-C, the T wave inversion is kind of a biphasic.
Exactly.
But I would actually ask everybody to pay attention to Rafique Bhai's reflex, that he was asking about patient, and also when I said chest pain, did you hear his reaction? That this is important, that EKG we always interpret and take care of the patient. Yeah, clinical context.
Yeah.
So we always need, I wanted to emphasize that there are many reasons for ST elevation, and certainly you can look at Brugada, but look at so ST elevation is not ST elevation MI. ST elevation, MI part is clinical. EKG does not give MI diagnosis, but by certain pattern in the EKG, we jump for MI. But it is important we have to pass board, I know that, but we have patients to look at. So if you look at this from the left to the right, the left ventricular hypertrophy, left bundle branch block, acute pericarditis, look at this last concave upwards. Then you can have pseudo infarction pattern and hyperkalemia. You can have the real anteroseptal MI. Yes, you can read STEMI despite right bundle. You can, and then this Brugada. Look at this Brugada pattern is the shoulder down, and we see this in acidosis, hyperkalemia, and other non-cardiac issues. And therefore, we follow the criteria, but still remember the clinical context. So what do we do for this patient? Anyone to, you know that I did take the patient to the cath lab, but anyone have any other thought? Will you take the patient to the cath lab right then?
Yes.
Or will you wait for?
I'll take to the cath lab.
I will do that.
Because the patient had cardiac arrest with VM.
Yeah.
So it's mandatory to look at the coronaries.
Yes.
This is very important. What both our faculty said, that this is important, that you don't waste time. But you may take to the cath lab, but you may have another kind of problem. So here you go. See the LAD, mid-segment stenosis, and then others. Look at that. You can see the coronaries.
There's also
so what we do now, and then I did the right also. These are all boring. I gave lots of nitroglycerin. In fact, I gave, just to tell Wadud, I gave a lot of nitroglycerin intracoronary. I also gave intracoronary nicardipine. And I also went through phase by phase, whether there is any change in systole versus diastole, because two things comes in mind. Is it a myocardial breach or is it a coronary spasm?
Yeah.
So just to show you for completeness, this is the right coronary artery. So what do we do now? The patient had a BFVRS, chest pain, EKG changes, and then so I thought that why not do a ventriculogram to see whether this is a Takasubu or not. Okay. So I did a ventriculogram, and what now? What after this? What to do? And I hope that Rafique Bhai can stay. I know he has another talk because there is some EP issue will come up in a second. Jamil Bhai, what to do next? Any?
You have shown the left anterior descending after injecting nicardipine.
Yeah, so there was no change.
No change, okay.
So what we did is I put an FFR, IFR wire.
Okay.
And then I got the IFR 0.92, 0.91. This is the volcano system. And now I'm on the fence. So you will start with intermediate lesion, and then we do IFR. You are in the intermediate zone. So what do you do now? Should I put an IVAS or? So what I did an adenosine 3 minutes infusion, 140 mics per kilo. And then FFR now, fractional flow reserve now, 0.97.
That's significant.
And the LV function was normal. So what do you do now?
Just a dilemma because the patient had cardiac arrest, had history of cardiac arrest.
Patient had cardiac arrest, yes. But where is the MI? There is no, I don't see any MI. So I don't know whether this is right or wrong, but I did a stent at this point. One of my colleagues who did not know the case, he made an excellent comment. He said, after the FFR, IFR, after the IFR, I would not have done FFR. But if you did, if you put the stent, you are right. If you don't put the stent, I would also say you are right. So I did the stent. I did the stent, okay? And then I did the IFR again. So now the IFR, which was 0.9192, it was 0.98, okay? And it looks nice. And then question is, what do we do next? So now the question to Rafique Bhai, that is this, because we cannot call it MI related. If it is primary VF, we don't put a ICD, right? We just treat the MI. So now how I define this, look at the troponins. This is 250, 361, 340. These are the 5th generation troponin high sensitivity. So roughly you divide them by 1,000. That's your 0.254, 0.361, 0.34. Echo normal LV function. Couple of chest pain, blood pressure control, patient is doing fine. So what should I do next? Rafique Bhai probably has left. DC, discharge home with dual antiplatelet statin blood pressure control, or give wearable jacket, live vest, medications, or put ICD before going home?
I'd put a live vest.
Okay, but you then buy time for 3 months.
Yeah.
And then see how long you will do this.
And for the money, I'll go for that. But I would be asking the patient again: was she taking any anything else, any antihistamine or anything else that can have induced that arrhythmia?
Okay. Okay. So interesting. We did toxic screen. Toxic screen was negative. Liver function test, everything was negative. The pharmacy that she goes to and takes losartan, we actually checked with that pharmacy if she was taking any other medications, because patient denied any other medications, and pharmacy confirmed that she was not taking anything. And we actually told her that this is a serious issue. Is there any confounding issue that you taking? Be truthful to us. And she said that she was not. So what we thought was that this is a secondary prevention following the V-fever arrest. So this will be too high risk to let her go home without a device. And our electrophysiology guy, he initially thought that ischemic substrate good enough. When I told him that I'm not totally convinced that this is enough to protect her. So she got subcutaneous ICD for aesthetic reason and did fine. So another patient, if I have time quickly, 58-year-old came in with syncope, shortness of breath, some back pain, and she was in another hospital, then left against medical advice and came to our hospital. And this is the EKG in our hospital. And this is little tough one, but quite interesting. The EKG sinus rhythm, we see ST elevation in 2-3 AVF, also V4, V5, V6, and maybe in lead 1. There is some EKG that V1, V2, little bit of ST depression, and that was confounding, telling us that this patient may have acute coronary, but we debated. I actually told the on-call team, because I got a copy, that look at the AVR, that there is PR elevation. So PR elevation, and maybe more than one territory, it could be pericarditis, acute pericarditis, but question is why. So and in the meantime, patient dropped blood pressure. So if the patient drops blood pressure and EKG changes, I tell the fellows that I want two things. A stat chest X-ray and bedside echo is a must. And this is the chest X-ray. Looks like big heart, but lung feels not flooded with severe congestion, right? Relatively protected lung. So, and then this is the repeat EKG, and I show you the echo. So any comment on the echo, but LV function is not normal. And I give you these issues with the labs in other hospitals and our read, but look at this echo that was done by the tech later, maybe within an hour apart. So this is the best one. Any comment on the echo?
There is some collection around the heart in the
Yes.
peritoneum.
So and look at that.
And white
like some organized material in the heart. So we did look at this, and we did the tamponade physiology, and fellows sometimes argue about across mitral valve, the respiratory variation, is it 25%, or across the tricuspid valve, is it 40%? I say that, remember, the tamponade physiology in the presence of hypotension may not meet those criteria. And in the presence of intracardiac shunt, you may not have tamponade physiology.
Yeah.
In the presence of severe AI, you may not have tamponade physiology. In the presence of severe bleed, particularly in the trauma, we are level 1 trauma. Patient has severe hypovolemia, blood loss, and chest trauma, tamponade, but you may not see tamponade physiology, but you may see the collection. So because of that, we said, okay, we do convince the surgeon for a pericardial window, but for the sake of time, I'm skipping this. But look at the all the coronaries are okay. But look at this tracing. This tracing is important because it is a simultaneous left ventricular end diastolic pressure and right ventricular end diastolic pressure. There is equalization of the pressure. Another thing we do is the inspiration and expiration and see whether there is any dysynchrony or synchrony, restrictive and constrictive. But in any case, this was equalization of the pressure, you can see. And then the patient went for pericardial window, and unfortunately also had anemia. We had to transfuse and then stabilize the patient. This, if you ask me about whether we do routine pericardial window, or we do routine tap, or we do routine this hemodynamics, Morton Kern, where I used to work with, he would love you if you do the right and left heart cath with a pericardial tamponade patient. But honestly, we are kind of lazy. We don't do it. We just do the ultrasound guided, sometimes pericardial tap. One thing lately I have seen very helpful is that we use micropuncture needle and use the micropuncture needle. And I'm actually pretty confident now to do it apical versus subxiphoid. So you decide where the fluid is most, and then use micropuncture needle. Is pretty safe actually to go that way with the guidance of the ultrasound. But if you are in the pericardial cavity, before you do anything, inject a microbubble, get some fluid out first. So that was good. So, and then we talk about EKG all the time, but I will finish with this one. If you have any comment, see the patient presented with 64-year-old lethargy, fatigue, STEMI activation. So what you do?
In this patient, widespread ST depression in different coronary territory and ST lesion AVR, one possibility, even without chest pain, is left main disease.
Yeah.
Yeah, and I would definitely agree with that. And then question is what we do. So funny enough that something was done and this EKG was there. In about 6 hours post.
Severe anemia.
Severe anemia, correct. So severe anemia.
Global ischemia.
Yeah, global ischemia. So the question is, now what you do? Troponin came small positive. Echo LV function low normal.
Do a stress test in this patient if you are thinking of ischemic coronary artery disease.
Hafiz bhai, after correction of the hemoglobin,
yes,
I would go for a stress test.
Okay. Yeah.
And if that indicates, then I'll go for CAP.
Okay. A stress test came normal, but
Okay.
fixed inferior defect. And with, I don't know what's your impression with the nuclear cardiology read. Sometimes the nuclear, I call it unclear. And it becomes a, it becomes a little mambo jumbo. So
Yes.
I usually try to do, and particularly, no offense, if the nuclear nuclear stress test is read by the radiologist, it becomes a nightmare sometimes, because not everybody is same and they don't look at the clinical context. So their read sometimes can be problematic. So what do you do?
What was the ejection fraction post transfusion?
Before and after, good point. I called it like low normal before, but after, no major issues.
So if no viability, normal, then follow up the patient.
So, the funny thing is that this patient, echo EF, and then the fellow was telling me the EF, and then stress test is done, but I hear a murmur, and I said, echo normal, but what about the aortic valve? Did you look at the they got the preliminary from the technician, and then they got the EF normal, but they missed the whole point that this was a severe AS with the bicuspid aortic valve, and then LV function was okay. So we did so now LV function normal, but severe AS, GI source is likely, could be Hades. You need the GI workup, but the GI doesn't want to do the GI workup because they said that you fix the valve first, then we'll do the GI workup. So what will you do? Troponin. Troponin was positive because they think it's a mine. They are afraid because the GI doesn't want to do anything.
What was the BNP?
BNP, I don't remember, but it was not that high, like a couple of hundred. Creatine, luckily, is normal. So I usually call the anesthesia. I said, what you are afraid? Because the issue is not with the GI doctor. Issue is with the anesthesia. So I call the anesthesia that, look at read the echo along with me. So you will be okay. Just give the sedation that does not drop the blood pressure. You'll be fine. So patient had this. There was some angiodysplasia, but no active bleed. Hemoglobin stabilized, and vast majority of the patients, they get better with the replacement of the valve. So, and we did the cath. By the way, we ended up doing the cath. Coronaries were fine, but the valve was indeed tight. And then it was happy ending. So that's all we have. Any comments?
So first,
I think
first patient. So what is the risk of stent fracture if you put a stent in myocardial breach?
No, I don't think this was myocardial breach, because I try not to put any stents in the myocardial breach. But for the best thing to do for the myocardial breach is to go frame by frame and then see whether there is any phasic variation in systole and diastole. So we did not see any myocardial breach, and we see fixed obstruction. Question is it a localized fixed obstruction with severe spasm? And in the severe spasm, you can have fixed obstruction. So we give nitroglycerin and then nicardipine, but we did not see anything changed. And then in the case of myocardial breach, actually, Dr. Karn has published, if you do the IFR or the wire and leave the wire, you can actually see the changes in the number of the IFR values with the phases, systole and diastole as well, if it is severe. But you are right, Arun, that we try not to give stents because the chances of a stent fracture is bad. Sometimes we see, and we have done a couple of cases, at least in my hospital, that they are associated with HOCM and hypertrophic cardiomyopathy, and some of the LAD runs through the fibers. So we tell the surgeons if they're going for myectomy. We just had one on Friday that take this, go through that area and then lift the myocardial fibrils and relieve them. But for that alone, I have not sent anybody to OR. Any other comments?
Actually, this case actually proves the importance of clinical context.
Absolutely.
Hafiz bhai, can I share my experience today?
Yeah.
I had a patient referred from another hospital. She had the patient became unconscious. He had trauma. He is a post-bypass patient. He had some trauma in his ankle, did not pay attention to it, but then he developed fever, slight fever at night when going to bed. And at the dead of night, he had severe fever and became unconscious. He was taken to a hospital. They had given him some antibiotic. They found out that he had raised troponin, and they were so much worried that the patient had MI, and they referred to me. I find out even when the tropi was high sensitivity tropi, actually it was high, not that high. Again, the patient had at that time ejection fraction of 55%, post-bypass patient. And the procal was very high. I said, this is the case of septicemia. The patient didn't complain of any chest pain. This is very likely septicemia induced myocardial injury. This is not non-STMI. So don't pay attention to that. Just treat the infection, and he is hemodynamically stable. Continue the present medication. Don't give too much anticoagulant, etc. Now the patient is quite all right. Quite all right. And I was saying that I'm not going to do any cancer or anything. Just treat the infection, go home. Then after a week, I will do the ETT. If there is something wrong in there, only then I will go for cath. You don't have any cardiac issues so far, I see.
And actually, we looked at our critical care patients when we published. If you look at the critical care patients and then sepsis across board, if the troponin remains less than 1, I call it mini troponin. So there is no typical rise and fall. Less than 1, and LV function normal, the chances of, because we followed them through the cath lab, the chances of any hemodynamically significant coronary stenosis is very low. However, if the troponin is more than 5, even if it is non-related to coronary disease, down the line, if you do cath, they may have significant coronary disease, may not be necessarily MI, but high-grade stenosis. What happens that these are like a complex group with type 2. So when there is a demand-supply mismatch, they get more troponin, but a very, very small troponin is a good thing with normal LV function. And you have time, you can evaluate them later.
Hafiz bhai,
Yeah.
Professor Abdul Salam, I have a comments regarding your last case.
Yeah.
Case was probably a bicuspid aortic valve with some aortic stenosis and as well as regurgitation. So, and patient presented with anemia. So, exclude any subacute or acute bacterial endocarditis in this case, because in case of chronic or subacute or acute bacterial endocarditis is usually predisposed with congenital valvular condition associated with anemia. So that is my point to that is my point to discuss.
Yes, absolutely. A very important point, because that can be subacute bacterial endocarditis with marrow suppression, and then is the anemia because of that or anemia with the GI bleed. That's why if there is nothing in the GI And then blood cultures, you pay attention. We actually did the TE also, and there was no valvular vegetation or anything. For some reason, because the bicuspid aortic valve, the aortopathy may be common. So we did not only the TE, we also did the CT angio, make sure that there is no associated quark, and the valve replacement alone is good enough. Yep.
Thank you.
So I'm good. Wadud, I think we're already late night, about 11.
I think we have had good experience with different type of ECGs in different scenarios. We enjoyed that very much. And today, the lecture was supposed to be given by Prof. Atahar Ali, as we have known that his mother is very ill on life support due to COVID. At the end of today's program, let us all together pray for Prof. Atahar Bhai's mother so that she gets well very soon. And let's pray to God Almighty that all of us remain in good health so that we can meet again in the next week. The topic of the next week will be deciding later on, depending upon the situation there, whether all of us are remaining well or not. Thank you, Hafiz Bhai. Ribhu,
Thank you.
You'll give us the we'll give out the instruction later on for the next class.
Okay.
So thank you again, Beksimko and Ribhu, and the faculties and everyone who are here, and all the
Thank you all.
audience who has been joining us regularly. Thank you, everyone.
Thank you, and good night.
Good
Good
night.
night.
Assalamu
Thank you,
alaikum.
sir. Assalamu alaikum.